First of all, we're going to think about the adrenocortical diseases, okay? And they include things like Conn syndrome, Cushing syndrome, and apparent mineralocorticoid excess syndrome. So remembering, of course, that the adrenal gland sits on top of the kidney. The adrenal gland has got an adrenal medulla, okay? And this is where your adrenaline is released from, and the adrenal cortex, hence the adrenocortical diseases, which is where we get the release of aldosterone and we get the release of cortisol from. So in the adrenal medulla, as we talked about, in this area, this is where you get the release of adrenaline, and you can get what are called phaeochromocytomas. These are catecholamine secreting tumours, generally noradrenaline or adrenaline. They're quite a rare, in fact very rare, but treatable cause of hypertension, and they're basically stimulating a prolonged version of the fight or flight response. And what people will get, they'll get episodic palpitations because the catecholamines seem to be secreted episodically. It increases heart rate and stroke volume, you get generalized vasoconstriction, you'll lead sweating and tremors and hypoglycemia, so increased blood sugar, because of the effects of the adrenaline and noradrenaline. Diagnosis is usually through urinary catecholamines over a 24-hour period, so you'll see an increase in their release. Treatment is via surgery. There are other endocrinopathies that are associated with hypertension that we won't really go through. So primary hyperparathyroidism, so too much parathyroid hormone, hypothyroidism, too much thyroid hormone, and acromegaly, too much growth hormone. What I do want to cover is Conn syndrome. Okay, now Conn syndrome is actually quite a common cause of hypertension. It's the most common cause of secondary hypertension. About 10% of patients, though numbers vary depending on the literature, between 5 and 30%. So it's actually quite common, though it's underdiagnosed. 65% are due to aldosterone secreting adenoma, and 35% due to bilateral hyperplasia. And so the clinical signs of Conn syndrome are hypertension, hypokalemia, so that's low amounts of potassium in the blood, and an alkalosis, a metabolic alkalosis, leading to muscle weakness, cramps, tetany, pins and needles. So bearing in mind that it's an aldosterone secreting tumour of some description, I want you to predict, tell me, so press pause again, what's going to happen to aldosterone levels, renin activity, the aldosterone-renin ratio, sodium, potassium, hydrogen and blood volume. Of course, you need to know what aldosterone does to be able to answer that. So aldosterone stimulates sodium retention in the kidneys and water follows. And at the same time, it stimulates hydrogen ion excretion and potassium ion excretion. So you need to be thinking about those two functions. So press pause and have a little bit of a think about what variables, how those variables, those aldosterone, renin activity, etc., will change in Conn syndrome. Okay, so the first one's easy. You have an aldosterone secreting tumour, so aldosterone levels will go up. What will happen to the renin activity? Well, through negative feedback, more aldosterone, less renin, so that goes down. So therefore, what happens to the aldosterone-renin ratio? That, of course, goes up, and that's one of the things that's measured. Sodium levels will increase. Potassium levels will go down. That's your hypokalemia, because aldosterone secretes potassium, excretes it out of the kidneys. Hydrogen ions will also go down, because that's another of the functions of aldosterone. It excretes hydrogen ions, hence the alkalosis. And your blood volume will go up. Sodium is reabsorbed, water follows, blood volume goes up, blood pressure goes up. What about Cushing syndrome? Well, Cushing syndrome is caused by an excess of cortisol. There are many reasons that cortisol levels may go up. But what does cortisol do? Well, one of its really main functions is to facilitate adrenaline synthesis and potentiate its vasopressor effects. In other words, its effects on vasoconstriction. Remembering how cortisol is actually released in health, so there are lots of stimuli. So circadian rhythm, cortisol is released at higher levels first thing in the morning, preparing you for the stresses of the day. It's your long-term stress hormone. It stimulates other things, so other stresses can activate it, rather than just preparing you for the stresses of the day. Your physical stress, emotional stresses, hypoglycemia, low blood sugar, that is a stress. Cold exposure is a stress. Pain is a stress. All of these things activate the hypothalamus, which then goes on to release corticotrophic releasing hormone. That then stimulates the pituitary gland, the anterior lobe, to produce adrenocorticotropic hormone, ACTH, which stimulates the adrenal cortex to release cortisol. Cortisol has negative feedback on ACTH release, and ACTH inhibits the release of CRH. Cortisol also inhibits CRH. So you've got this whole feedback loop going on with cortisol release, and the same as most other endocrine systems. They also have these negative feedback loops in place. And what does cortisol do? Well, it does lots of things. It stimulates gluconeogenesis, so it increases blood sugar levels. Stimulates lipolysis, so therefore lipid breakdown. Think about it, it's long-term stress hormone. You want to maintain your blood glucose levels. You want to maintain your glycogen levels, okay, in case you get attacked by an animal. If you're in the wild plains and you're injured, you want to have you want to be able to have those glycogen stores ready to run away quickly if you have to. Lipolysis is so that most of your other systems are using fats rather than glucose. It does stimulate proteolysis, so breakdown of proteins. That's not a great thing, but think about it. You need amino acids to repair if you're injured, you need amino acids to repair that tissue. It causes insulin resistance, so therefore leads to type 2 diabetes. It decreases inflammation and decreases immune function, hence why corticosteroids are used in asthma, for example, and why they're used following transplant to reduce immune function and therefore reduce rejection of tissues. The most common pathological causes are what are called ACTH dependent. In other words, you have a pituitary tumour or adenoma, which is the most common cause. That is called Cushing's disease. So that is due to a pituitary adenoma. You have ectopic ACTH, which is often from the lung. So the lung produces huge amounts of ACTH. That's about 10%. You have then the ACTH independent. So you may have the adrenal cortex, adenoma, and carcinoma, again, releasing cortisol directly. But clinically, the most common cause is those taking glucocorticoids to treat other diseases, such as asthma or rheumatoid arthritis, or, like I said before, immunosuppression following transplants. So really, what I want you to think about now, this is, again, we're thinking about the endocrine system, we're thinking about feedback loops. What plasma levels of corticotropic releasing hormone, adrenocorticotropic hormone, and cortisol would you expect in individuals with Cushing's syndrome compared to normal? So what will your CRH levels be if you have Cushing's disease, if you have an ectopic ACTH secreting lung tumour, or if you have an adrenal adenoma? And all I want in each case is increased, decreased, no change compared to normal, or compared to reference ranges, if you want to call it normal reference ranges. Remembering that ectopic ACTH is ACTH secreting lung tumours secrete huge amounts of ACTH in an uncontrolled way with no negative feedback going on because we're in the lung. So let's go Cushing's disease first. So press pause, hopefully you press pause and had to think about this. So let's think. Cushing's disease, what will happen to the CRH? CRH levels will go down because in Cushing's disease, you're secreting high amounts of ACTH, which is the next one, okay, so high levels of ACTH. That then stimulates an increase in cortisol. That increase in cortisol works on the hypothalamus to inhibit the release of CRH. Go back a page and have a look at those feedback loops. Ectopic ACTH secreting lung tumour, CRH. CRH levels are dropped because the huge amounts of ACTH and the huge amounts of cortisol are having negative feedback on CRH. But the whole point about this, the difference between Cushing's disease and ectopic secreting tumour, is the amounts of ACTH and cortisol that are being released. What about an adrenal adenoma? So that's secreting cortisol directly because of a tumour. So that cortisol has negative feedback on the hypothalamus, negative feedback on the pituitary, but we have high levels of cortisol. And that's how you can distinguish, just very simply by taking blood tests, where or a potential cause of Cushing's syndrome. Another cause of endocrine hypertension, quite an interesting one, is apparent mineralocorticoid excess syndrome. And that occurs because cortisol and aldosterone actually have similar affinity for the aldosterone receptor. That's a mineralocorticoid receptor. So in vivo, selectivity for aldosterone is achieved due to inactivation of cortisol to cortisone at the receptor site. So therefore, aldosterone occupies the aldosterone receptor, not cortisol. But cortisol is present in the blood at 10 times the concentration of aldosterone. So it would easily overwhelm this activity at this site if it wasn't being inactivated. So if we're looking at what's happening, here we have cortisol, here we have aldosterone. And what happens is they come along to the cell, they want to come to the receptor, but cortisol is inactivated to cortisone. There's an enzyme that does it, okay, 11-beta-hydroxysteroid dehydrogenase. Let's not worry too much about the name. But cortisol is deactivated, which means the aldosterone can bind to the receptor and have the effect, reabsorbing sodium, water follows, increased blood volume. And because cortisol has been deactivated to cortisone, it doesn't bind to the receptor. And that's what's happening in you and me, okay? The cortisol really isn't activating that aldosterone receptor very much. So what might cause an increased stimulation of the mineralocorticoid receptor that is non-aldosterone mediated? So you may have an inherited deficiency of this enzyme. So if you don't have very much of this enzyme, you don't break down to cortisone, so cortisol can now bind to the receptor, causing an effect. You can have inhibitors of this enzyme. For example, licorice. Licorice inhibits this enzyme, so if you have loads and loads of licorice, you have more cortisol, more binds to this enzyme. And of course, ectopic ACTH secretion from the lung. You get so much cortisol that this enzyme cannot deactivate it all. So the huge amount of cortisol that's produced can bind to the receptor and activate sodium retention, and therefore water follows. So some review questions. Again, press pause, have a think about the answers, and then we'll go through them. So, which of the following are true regarding adrenal causes of hypertension? Conn syndrome is due to a renin-secreting tumour which stimulates excess aldosterone secretion from the adrenal cortex. That is incorrect. It's an aldosterone-secreting tumour or gland hyperplasia. Cushing's disease is due to an ACTH-secreting tumour in the pituitary gland which causes excess cortisol secretion from the adrenal cortex. That is correct. It's a specific cause of Cushing's syndrome. Cushing's syndrome is due to excess cortisol of any cause, including prescription medication. That is correct. Phaeochromocytomas are often due to adrenaline-secreting tumours from the adrenal cortex. That is incorrect. They are from the adrenal medulla, not the adrenal cortex.